Thank you for the invitation. I understood that it was purely economic reasons from Dean to invite me because, as he said, I'm originally from Germany and I'm living in Norway now, so it's again two nations and two presenters in one. I'm from the University of Tromsø, and I'm not from the University of Tromsø because since 2012 it's UIT, the Arctic University of Tromsø, and it didn't sink really in among ourselves because, as you can see, this is the original template we are supposed to use for PowerPoint presentations. And you see down there University of Tromsø and up there UIT, the Arctic University of Tromsø. The background is that we have merged with the former University College of Finnmark, which is part of the where my institute is part of. And in the program, Dean announced me as sitting in Alta, which I do not. I sit in Tromsø. From 2016 on, UIT is a construction with campuses, with physical representations in Tromsø, Alta, Kirkenes, and now in Harstad and in Narvik. So it's quite a stretch. So I think we qualify as covering some remote areas too, even if we do not have these 1,000-kilometer distances like you have in Australia. My presentation is on workforce coordination and skill mix in the Norwegian Coordination reform. So it's a myopic look at over the border on something which was supposed to do things in healthcare or in care better than we did. Yeah, maybe you find something in it. I would like to correct a misconception regarding the paper that Dean mentioned. So anything you might read in the future which you do not agree on, that's on Ellen and Dean. Yeah? So the one you agree is, but that's another one. I noticed that you are working together in a Nordic network for rural medicine. For me, the point in my presentation is about that rural medicine or medicine is something else than healthcare, and healthcare is only part of what care encompasses. Let me start with a question to you. How many of you are physicians? Could you just raise your hands? Thank you. How many of you are nurses? It's quite still a mix. Yeah? I have expected that there were many more physicians than nurses, and I'm very relieved that it's not the case. I'm quite convinced that if we would have a similar event in Norway, that most of them, of the audience, would have been consisted of physicians, not nurses. Not to speak of social workers. Are there social workers among you? Great! I'm not completely alone. My background is as a social worker from Germany. I moved to Norway, to Tromsø in 1999, awful lot of time ago. And it's only due to the one woman in my life. So I wasn't captured by promises of several wives and donkeys and whatever. So we moved there. My wife is Norwegian, and I studied sociology there. I've worked as a medical sociologist and first in a psychiatric hospital, and then as a researcher on cooperation in mental health care. And that's where I want to start. Now, as you can see, I'm at the Institute for Child Welfare and Social Work, so the ring has closed again. But my interest is still in the cooperation across the social and health care interface. Peter, could you give me a friendly wave when I've used up 15 minutes and maybe not so friendly wave when I'm still talking after 20 minutes? Yeah, where is this? I want to start with some recent reforms, and recent is not quite adequate because it stretches, as you can see, back to 2006 with the NAV reform, the social service reform in Norway. Another reform came into being for full in 2008, the National Program for Mental Health Care, and now the coordination reform, where the white paper was published in 2011. The reform is supposed to be over or done, implemented in 2015. All these reforms had some things in common. They asked for more cooperation between the services, and the more should not only be more, but it should be better service coordination, and the whole thing should end up with a holistic parcel to the end users. And so what you need, what you are expecting from any kind of the Norwegian welfare system should have something to do with each other. And I suppose, I don't know it, but I suppose that you are quite familiar with this kind of thinking here in Sweden too. Am I wrong? Doesn't the Swedish government publish an awful amount of paper demanding more holistic services? Does it? Okay, I won't ask you anymore, you don't give answers anyway. What these reforms also had in common was that they were mostly targeting more cooperation across organizational boundaries. What they didn't address, neither of them, was the interprofessional relations, which are, I think we all agree about it, are basically a basic ingredient for making things, cooperation better. There were, in the coordination reform, which is my topic today, there were some challenges. The first one was that obviously the need, which everybody agreed on, for coordinated services was not addressed enough. And here I would just mention that basically the one who initiated the cooperation reform, the Ministry for Health and Care Services, at that time, he intended the coordination reform to be something which encompasses the whole service, all the services that the welfare state provides. Health and social care, social services should work together and end up in a holistic parcel which was tailored for the end users. What came out of it, this white paper, which defined what the cooperation reform was supposed to be, was only targeted and was only talking about health care services. So anyway, also in this white paper, it was highlighted that the need for coordinated services was not addressed. The second was that it's also a European movement, maybe a worldwide movement, that we should not wait until people do have a health problem. We should do something beforehand. So prevention was a serious issue, which ended up in an own law. The third challenge was what Ellen was highlighting already. So lots of what you hear from me, you have heard before, and you have known in beforehand anyway, that the demographic changes and the increase, particularly in chronic conditions, can reach dimensions which, even for rich Norway or rich Sweden, can threaten the whole economic financial basis. So, to address these three main challenges, the first one is not so exciting. When there is a need for more service coordination, we have to coordinate more holistic and do more about it. When there is not enough focus on health prevention, we have to do something about this. In both health promotion and prevention. And the third one, that's a kinky one, or an interesting one, when the demographic changes and the increase of chronic conditions are threatening the whole existence of the welfare state, we have to, and now it comes, we have to give more responsibility for health and care services to the municipalities. And that this one is... I find it a bit, it's not quite so obvious like the other challenges and the solutions. So why is challenge 3 so answered adequately by giving the responsibility to the municipalities? Well, obviously because that's where the people are living. You know, that's also where the workforce mix, where people who are receiving services are feeling whether or not the workforce mix is working. Some numbers, and you know them. It's a Norwegian expression, the Elderbølgen. Do you have something similar in Sweden? The expression, the term Elderbølgen, it's an elderly wave. I don't think there is an English expression for it, huh? Yeah, exactly, yeah. Okay, that's a new one. I didn't hear that. I think it would be a bit politically incorrect to say this in Norway. You get the drift. That's an old statistic. It's from 1999, and I put this up because at least for the first two columns, now we can look at it and see if they have had an adequate perspective, and they did, almost to, at least if you talk about hundreds of thousands, it's quite fitting, and there is no reason to expect that by 2020 this development has a curve downward. But that's, well, I mean, the people get older, that's not the problem. The problem is that there comes another wave with the Eldebølgen or the Tjøttberg, or what was this? The Eldeboomen, yeah. So there comes another development that's, I mean, people do not only get older, they get older, they are getting sick, and they are developing chronic, well, not chronic diseases, chronic conditions. No, it's a state of life. As the older you get, you will have something. I have gotten something. Shall I tell you how old I am? No, I'm on the bad side of 50, and I got Pogadra, and I will keep this until I die. And on the way towards dying, I'm probably going to develop several other chronic conditions. And it's not something anybody can ever cure. It's something I have to live with, and I have to make the best out of it. And that is the big challenge. Now we are meeting not only a Tjøttberg, but we are also meeting a chronic bølge. Wave, Berge. So people are getting older, and they are getting older more with chronic conditions where there is nothing to cure but lots to care for. Let's put in a little bit better language from somebody who knows it better than me, an epidemiological shift from communicable diseases. Anyway, what you can cure is one thing, but what's going to develop much more is the shift towards chronic conditions. And that's why I would like to highlight that the future, when it comes to welfare services, is chronic. That's the big challenge we have to address in one way or the others. So how was the third challenge of this Kronikerbølge addressed in the cooperation reform, and how was it translated into practical policies? There was something... Oh! Forgot a slide, sorry. So what's so special with this Kronikerbølge? First of all, these chronic conditions, you know them. If you have one, you are, I think Onassis said once, you can have one, with boats it's like with rabbits. You can have one or you can have many, but you can't stop with two. So it's the same as chronic conditions. If you have one, you are probably going to develop several. Quite a lot, and it's always a given. If you have something which hinders you in walking a lot, no? You're going to develop, your blood pressure will be an issue, your digestion will be an issue. You have lots of these conditions, and so the multimorbidity is an issue which is not addressed enough. And it's if you have somebody who, an older relative, you will know this, that if you look at these dosette, it's Norwegian expression, the pill box. Sometimes you can really wonder how anybody can keep control of it. Now this multi-pharmacological explosion you are going to meet, and then you forget taking this stuff, and that's when you need the care services, and that's when things go good, or can go well, or can go really bad. So that's also something with chronic conditions. Until you are diagnosed with one thing or the other, you are going to feel. You're probably going to have several years where you feel bad. Now, but you can't put your finger on it. If you break your leg, you're lucky, no? Because that's an easy thing to diagnose and to treat, and you go on with it. If you have this bunch of multi-morbid, diffuse conditions, it's much harder to do something about it. And then, of course, chronic conditions, otherwise they wouldn't be chronic, they are chronic. You have them, you keep them, and you die with them. So that's also something that has some consequences. That means that you have a need for services, for lots of services, welfare services. Treatment is but one of them. That's the medical part. Or maybe for psychologists, it's one part of the whole package. But you need care, and you need, don't forget this one, the support and the counseling, the social support. All this follows with chronic conditions. because it's so easy. I was recently on the UFA conference in Milan, where a colleague had a very great case study of Mary. Mary was an 85-year-old woman, and she lived as she lived. Kids in another place, neighbors dying, basically living alone. She had problems with hygiene, and when the district nurse came in, the community nurse came in, there was half an hour every fortnight. Then Mary was stressed because she knew the nurse was coming, but all these other hours in between, where the issues become issues. So what do we do with them? Anyway, this broad sample of services people with chronic conditions need does also mean that cooperation is not only an issue between health services, but also between health and social care professions. So again, back to the cooperation reform. How was this translated into practical policies? The law is always easy because it's written and you have to relate to it if you want or not. There were three laws actually that were changed, but two I want to mention now. The public health law, and that was addressing the challenge too, not enough focus on prevention and health promotion. The second law was a law which was called, that is directly translated and probably you can, the Norwegian title is the correct one, Helse- og omsorgstjenesteloven. It's a law for health and care services in the municipalities or in the communities. This law merged two older laws. On the one hand, the existing law regulating health services, which is now still in the title, but it also merged the social service law. And by merging them into one law, what happened was, is it a friendly wave? Okay, thanks. It kicked out basically the social services, the social care services from the legal framework. So, the consequences of this, first of all, now care is solely health care. Social care was pushed out. The second consequence was that services are focused now on health problems and not this issue of active and self-determined living, I've called it. This part where somebody comes and says, come on, let's go to this shop. I know it hurts, yeah, but you have good of some fresh air, and let's call your children you have lost contact with, or the relative, or the old friend you mentioned last week or so. This is something which we call, and I'm sure it's not an English word, but it's the closest I came, the healthification of social care services. Not social services, but social care services. Oops. So to make all these observations, to found them empirically, I did a qualitative content analysis of the white paper, which is called the Coordination Reform. I made first a frequency count. How often did certain terms come up? And in this case, I was looking at how often do certain professional titles come up in the reform. The second one, I looked into the text. What does it say when it mentioned physicians or nurses or so? And I also looked particularly at, are they supposed, these professional groups, to work together, and who is going to lead the madness? So that came out. Physicians, you can see, a GP, that's fastlege, that means the Norwegian term lege. Every time a fastlege turned up, it also turned up as lege. So never mind, you see physicians ended up with a obviously dominating, it was dominating professions mentioned, while to my big surprise, even nurses were hardly mentioned. And if you see at social workers, all this, what the new law should fathom, the social care services, they weren't mentioned at all. So, the results from the contextualization, very brief. When physicians were mentioned, they usually talked about coordination as an issue of physicians, from physicians to physicians, from hospital physicians, specialists, to GPs. A new issue was, which came with as an obligation for the municipalities, were interdisciplinary teams, important tools, yes, especially mentioned for rehabilitation, chronic mental health and palliative care, but also others. But in these teams, physicians, when they mentioned the professions represented in these teams, physicians are not part of this. And I still don't get it, why not? No? So they are aside or in addition or instead, I don't know. Then they also implemented some new coordinating bodies, which is fine. Have a particular body, both in the hospital and in the municipality, who is supposed to coordinate. This is a great thing, but, now comes the but, we have already coordinating bodies in Norway which work very well. We have case conferences, we have individual service plans, where usually a large group of professionals is sitting around a table with a patient, with the end user, asking what do you want, what do you think you need, and how can we make this work. But these bodies were completely apart from the new coordinating bodies that have been established. Then the last result was that social care was mentioned, Sheldon, but never included into the new bodies which were established in these interdisciplinary teams. Now, that's the white paper. For our practical purposes, no municipality I know of has made a clear cut and said, okay, we put another body on top of what already is existing. They usually merge it, and in these teams that are there are also social workers, and there are those people who are, especially in small communities, those people who are available. But I can't get it. I don't understand it, and I find it completely wrong that this is not expressed in the white paper and also the following Vorschrift, the following documents that were issued. So the conclusion, or conclusions, the coordination reform, frankly, it does lay the ground for more cooperation, but in two different directions and not better cooperations. So it serves the purpose of better cooperation between hospital physicians and GPs, yes, but on the other hand, there is, when it comes to care services, I think nobody really knows what they are supposed to do, but everybody is trying to make the best out of it. Social care, that's my particular perspective as a social worker, has been pressed out in favor of health services, and that's a development which I find very hard to swallow. So, is the fish coming?
No, you have time.
I still have time. Anyway, I'm done. There was just a brief glimpse into the cooperation reform, which is one attempt to sue the different parts of the healthcare system better together, and some critical remarks from my side that I'm not so confident that it's going to work as it's intended to. And I would have been very interested in your Swedish perspectives on the whole thing, and also get a glimpse into how you in Sweden are handling this, especially when it comes to elderly care, because I still have the impression that elderly care is an issue for social care in Sweden, while healthcare is something apart. Am I wrong?
Elderly care is mainly done by the community, which is more of a social care.
Yeah. And it's also done by the communities in Norway, but that's not a social care issue. It's a health community care issue for healthcare.
But as we spoke to each other during the coffee break, and I think we have an opportunity in these rural areas to actually build well-functioning systems with collaboration, because we should really collaborate amongst these issues. But and we have done it. You told me about Senja, for instance, where they collaborated and made a very good work. But then when the bosses came in, they tore it all apart. And I think one of the things that we have an opportunity here to build good systems, but we really need to evaluate them properly, so we can actually send them upwards and say, you should do this.
Yeah. So my idea would be to provide a sample of best practice models, because as I said, I know for a fact that in lots of remote communities, or remote and smaller communities, as it is in Norway, there is so much good work to be done, and people are not looking so very much on professional titles. They're looking on who is available. And I told also to you, Peter, that sometimes they develop solutions which are on the brink of being not quite so legal, because there's nobody there who can take it. There are communities or municipalities who have lived for years with Danish, usual Danish physicians who come, who are flown in, are paid very well, but who do not know anything about the people living there or the conditions or the infrastructure. They make the best out of it, and the best case scenario is that they say, okay, you have done it all the years and it worked fine, just do it. No? Worst case scenario is that they come with an awfully bad high opinion of themselves as physicians usually, and they try to steer something which they don't know the first thing about. That's not so good working usually. But my idea would be to provide case studies, insight into, and especially the question which I was discussing with Dean. So what have you, I know you haven't had a physician physically here for 3 months because the one was terminated or disappeared before he was supposed to. Another one came a bit later. So what did you do? Because people are sick every day. People need care every day. So what were the ad hoc solutions you developed?